Good afternoon, everybody, and welcome to our Pregnancy, Birth and Blood Clots talk by Professor Fionnuala. Fionnuala is a consultant haematologist in the Mater Hospital and Rotunda Maternity Hospital. She's also Professor in the School of Medicine in UCD, and she's a Director of the Irish Network for VTE Research, Invite, with Professor Patricia Maguire. She co-directs the Sphere Research Group, UCD Conway Institute. She's also a member of World Thrombosis Day International Steering Committee and of the Invent Council. She's an Associate Director of the Wellcome Trust HRB Irish Clinical Academic Training Programme. Welcome, Professor Ainle, and thank you so much for doing this talk. We're really looking forward to hearing all about pregnancy, birth and blood clots.
Thank you, Anne-Marie. It's an absolute honour to be here with presenting to everybody out there, but in particular to be able to see you, my friend, my colleague, who's inspired us to do better over the years and has helped us to progress the care we deliver to all of our patients and their families and to raise awareness. So huge congratulations to you, Anne-Marie, to everybody in Thrombosis Ireland for making today the massive success that it's been already. So without further ado, I'd like to talk to you about a subject that's very close to my heart. So before we start, here are my disclosures. I'd like to begin with a story. At any time you can interrupt me and ask questions. I'd love this to be really interactive. And I think there is a chat box that we can share ideas through. But for the first half of the talk, I'm going to use didactic slides, and then we'll open the floor to some questions. My first story is a 31-year-old woman who was 6 weeks pregnant, and she tells her doctor that she developed a pulmonary embolism or blood clot in her lung 3 years ago while she was taking the contraceptive pill. And she wants to know what her risk of developing another blood clot is while she is pregnant. And by the end of this talk, we'll understand how we can make ourselves aware of our own risks when we're pregnant, how we can encourage our doctors to become aware of those risks, and what we can do to mitigate those risks. We'll also talk about what the knowledge gaps are and what we are doing as an international community to try to close those knowledge gaps. What kind of research is going on? So hold that story in your memory. So every woman who's pregnant has a higher chance of developing a blood clot or a venous thromboembolism than somebody who is the same age who is not pregnant. And this risk is highest after baby is born. And we'll go through that later on again. I'm going to be using some abbreviations during the talk because I think by now over the day, hopefully everybody will understand what a VTE is, a venous thromboembolism, or a deep vein thrombosis, a clot in the leg, or a pulmonary embolism, a clot in the lung. PE is otherwise known as pulmonary embolism. So why is it important to be aware of the risk of developing a VTE during pregnancy? Why is it important to understand your own risk factors? And why is it important to know what the signs and symptoms of a blood clot are during pregnancy? It's because it can be incredibly tragic. So VTE in pregnancy is a leading cause of death in pregnant women. We know from data from the UK and Ireland that VTE is right up there as a potentially preventable cause of death in pregnant women. And therefore, we have to be aware of the risks. We must never miss an opportunity to intervene to reduce a new mother's risk of developing a blood clot. And not only that, but VTE can have long-term consequences. These include post-thrombotic syndrome, which means painful, swollen leg, which has been affected by the deep vein thrombosis, which can be a lifelong consequence, or chest symptoms, the worst of which is called chronic thromboembolic pulmonary hypertension, and these can last for life. So it is important, it's absolutely crucial, that we take every opportunity to reduce the risk of VTE during pregnancy and in the postpartum period. And Anne-Marie and I are always talking about data. Do we have data to guide our management? Do we have data on blood clot risk in Ireland? And for once, we have fantastic data on what the risk of VTE is in pregnancy. We love data because they help us to do better. They help us to make decisions in order to take better care of our patients, to take better care of ourselves and our families. And we know that, you can see here, this is the non-pregnant period, all the way through to the 3rd trimester. And this is after baby is born. So you can see that the risk of VTE goes up for any woman who's pregnant. But it goes up again, it dramatically increases after baby is born. And that's a really important key message. The reason that's important goes right back to our Stop the Clot campaign last year. If you have recently delivered a baby, or if a family member or a loved one has recently delivered a baby, it's important that she knows the signs and the symptoms, in particular of a deep vein thrombosis, pain or swelling in the leg, or a pulmonary embolism, shortness of breath, chest pain, coughing up blood, collapse, feeling very unwell. I know you will have heard this time and time again today, but if you remember nothing else from today, I think that would be a key take-home message. And this is why. So data are our friend. And of course, pulmonary embolism during pregnancy in its most dramatic form can be absolutely tragic. And this beautiful illustration by our student, Renata Donsiu, illustrates the devastating potential effect of VTE or pulmonary embolism in pregnancy. And as I said, it is a leading cause of maternal death in every country. So what increases the risk of VTE during pregnancy? So let's think about that. First of all, why is it relevant? If we know that everybody's risk of VTE is increased in pregnancy, why is it important to know if you have other risk factors? Well, it's because even though a pregnant woman's risk of VTE is higher, it's still quite low. But if she has lots of additional risk factors, and we'll go through them now, and if they add up, then she can really have quite a high risk of having a VTE numerically. Going back to our very first story, that woman had a previous pulmonary embolism that was provoked by the pill. So her risk of having a VTE during this pregnancy should be in one of the highest risk categories. So does that make sense? We have to know, we have to arm ourselves with knowledge and know our own risk of VTE during pregnancy. And you don't have to remember every single item on this list, but suffice to say that there are many, many risk factors that have been proven to increase the chance of getting a clot in pregnancy. There are kind of things that are specific to the mother, being a bit older, having a little bit of weight on, being a smoker, having another medical problem can increase the chance of getting a blood clot. And as we saw in our case, having a prior blood clot. Things that are relevant to the pregnancy, so developing preeclampsia or other complications in pregnancy increases your risk. And then that really important time, delivery and after baby is born. And this is why it's so important that we formally assess your risks of developing a clot after baby is born. There are things that can arise that simply wouldn't be picked up if we didn't do a formal risk assessment. Look for risk factors after baby is born. So this is incredibly important. Data are our friends. And with a fantastic team of midwives, pharmacists, doctors, obstetricians, and laboratory staff and other colleagues in the Rotunda Hospital, we work together to ask the questions, well, what are those risk factors in pregnancy and postpartum? Are they common? And the answer is yes. This was an incredibly ambitious study, and it included a total of 21,000 women who delivered in the Rotunda Hospital. And what we found was that 4 in every 5 women had at least one risk factor. Now, having one risk factor mean that we have to act or do something different, but it is really important when they begin to add up. 1 in 3 women was either overweight or obese. 1 in 3 was over 35. So the demographics of our population are changing, and these risk factors are becoming more and more important. More than 2 in 5 women had 2 or more risk factors. And really importantly, 1/5 of women had no VTE risk factors before delivery, but developed them during the delivery or the postpartum period. These are things like having an emergency cesarean section, developing an infection, developing preeclampsia, having a complicated delivery. And these risk factors would simply not be picked up if we didn't do a risk assessment after baby is born. And I think today, one of the common key messages that we are all repeating time and time again is that formal risk assessment is so important, no matter where a patient is, in the general hospital, surgery, cancer patients, but don't forget that it is equally important in the postpartum period and in pregnancy. And to pick up what these risk factors are, to do it properly, and to tell whether you are at high risk of having a blood clot, we need to do a VTE risk assessment. There's no other way around it. And I know Anne-Marie would agree. And you should be involved in this risk assessment. So the next question is, well, look, it's not all bad news. Once we have done everything we can to identify risks, once we've done that VTE risk assessment, can we actually reduce the chances of a pregnant woman or postpartum woman developing a VTE? And here is where we do have some knowledge gaps. There are some excellent guidelines, but these guidelines at the moment are mainly based on the opinion of experts rather than on high quality evidence. But there is really good news on the horizon. The quality of data that is available to us has and is about to change dramatically thanks to the phenomenal work of so many people around the world and our patients who've so kindly been motivated to participate in these trials so that all women can benefit. And in this woman's case, she is very keen to prevent another blood clot. But the medications that are given, if the risk of having a blood clot is high enough, can also increase the chance of bleeding. So it's a delicate balance. We have to have these data. We have to do a risk assessment to pick out those women who are at risk. And it is really important to do this. It's not appropriate to give injections of a blood thinner to everybody, because these injections, while they are really good at preventing blood clots, they do come at a cost. And these risks are common. Minor bleeding, bruising at the site of injection, that can really upset people who have to inject because it can be, it can be unsightly and scary looking. Skin reactions are a lot more common than you think. Obviously, injecting yourself every day is painful, and that's something that we have to think about very carefully. And there's also the cost of the medication. So it's not an easy decision. However, working together, we are answering these important questions. So think back to that first case that I discussed. There was a woman who was 31 who had had a previous pulmonary embolism. She is in the highest possible risk category for getting a blood clot during pregnancy. So she clearly needs something to protect her against developing a blood clot. Until recently, there was no study open that, or there were no data to allow us to answer the question, what is the best dose of a blood thinner to help prevent a blood clot in a woman who's had a previous clot? But there is news on the horizon. There is a large multi-centre, multinational, randomised control trial termed Ainle, led by Professor Saskia Middelwerk in AMC in the Netherlands. We are very honoured to participate in Ireland, in many centres, including in the hospital that I work, the Rotunda Hospital, and also several other hospitals And the good news is that that study is nearing completion. So for the very first time, we will have the highest possible quality evidence to answer this question for women who are at the highest risk of getting a blood clot. There is also even more good news on the horizon. You will hear on Friday at the VTE Dublin conference from Dr. Leslie Skeeth, colleague of ours who's absolutely phenomenal in the University of Calgary in Canada. He is leading the POSTPARTUM trial. This very ambitious trial will ask the question, can low-dose aspirin help to prevent postpartum blood clots in women who've just had babies? It is an absolutely crucial knowledge gap. We do our best and we know we need to protect blood clots in these women if they have lots of risk factors. But really, the strength of the data are not good at the moment, and we need, and women deserve, the best quality data to guide our management. So watch this space, and we're very excited to hear from Dr. Skeeth on Friday.
This sounds really fantastic, and it'd be really good if you didn't have to inject while you were pregnant. Yeah. Oh my God, that would be amazing, because I injected myself and I found it quite traumatic at the beginning. You know, you're worried about hurting the baby. Are you doing the right thing? And then it's sore. Your tummy is, you know, it's stretched and sore, and it's hard to pinch a bit of flesh, you know. But that'd be amazing. I'm really looking forward to hearing that. That's great. Thanks, Fionnuala.
Thanks, Anne-Marie. And of course, this study initially would be focused on after baby is born, but you know, it's going to be I think an exciting couple of years to come as we work together to plan new studies. Going back to what has been done on the ground here in Ireland, again, the phenomenal team in the Rotunda Hospital has been taking this issue incredibly seriously, of course, given how close to our heart the issue is, and how high the risk of thrombosis can be in women with multiple risk factors. So in the Rotunda Hospital, we implemented a personalised postpartum electronic risk assessment tool, which means that no woman gets left behind. Every single woman gets a risk assessment done postpartum. And this helps to guide whether we need to protect that woman against developing a blood clot or not. This is personalised medicine, individualised VTE risk assessment. And huge congratulations to all involved, particularly Dr. Brian Cleary, who is the Chief Pharmacist in the Rotunda, Dr. Jennifer Donnelly, my friend and colleague, who is a specialist in maternal fetal medicine, and Dr. Fergal Shaughnessy, who completed his PhD in this area. And it's interesting, we need a lot more data, but you can see here rates of pulmonary embolism in the Rotunda Hospital since rollout of a package consisting of VTE risk assessment, awareness, and appropriate prophylaxis. And while these data are not statistically significant, there is a potential signal there that hope may be on the horizon. So moving on then to treatment of venous thromboembolism during pregnancy. And this goes back to one of my first key messages. And I think it's a message we've received all the way through the day. We must know, and everyone close to us must know, the signs and symptoms of a blood clot, because we can't diagnose or treat a VTE during pregnancy if we don't know that somebody has the signs and symptoms. And this is so important after a baby is born. If you remember nothing else from this talk, please remember the signs of a pulmonary embolism and the symptoms. Chest pain, shortness of breath, coughing up blood. And sometimes it can be unusual, I accept that. When we treat pulmonary embolism or deep vein thrombosis outside pregnancy, we use oral anticoagulants usually in this day and age. In the olden days, we used to use low molecular weight heparin or something like Ainle hyperclexane followed by Warfarin for several months, but now we use direct oral anticoagulants mostly for non-complicated VTE. But unfortunately, these medications are not safe in pregnancy. All the oral medications available to us can cross the placenta and are just not safe. They're not safe for baby. So the treatment of choice for venous thromboembolism, if it happens in pregnancy, is a medication called low molecular weight heparin. I know it's a mouthful, but it is the official term given to those medications that are injected, and you'll recognise them in Ireland as being either Ainle, tinzaparin, or clexane and enoxaparin usually. And the benefits of this type of heparin compared to the very old forms are, number one, it can be given as an injection under the skin, which is convenient. It doesn't have to be given frequently. The older forms of heparin had to be given several times a day, and now we can even use a medication once a day. The dosing is reliable. It's given in a fixed or weight-based dosing, and it has a much lower risk of complications than older forms of heparin. Do they work? Are they safe? Are they effective? So do they cause much bleeding? Is there a huge risk of having another blood clot? Well, there are some data available, and in one large study, including 174 patients who were using low molecular weight heparin for treatment, these were the risks of various complications. So they do seem to be safe and effective, and they are recommended by all international guidelines. So that's how we treat a blood clot in pregnancy. And this is a really important point. So where I work in the Rotunda Hospital, if a pregnant woman develops a deep vein thrombosis or a pulmonary embolism during pregnancy, we have the great fortune of having a world-class multidisciplinary team. Multidisciplinary means colleagues from lots of different types of specialties, and we all work together. We collaborate with you, the patient, to develop a plan that provides the safest care during pregnancy, and in particular around labour and delivery. And who's on this team? The obstetrician, clearly, and usually a fetal maternal specialist, such as Dr. Donnelly or Dr. Kent or Dr. Kennelly, and I'm forgetting so many people here. Hematologists, somebody such as myself, an anaesthetist who will think about the best way to manage pain around labour and delivery safely while still being able to protect you against a blood clot and reduce the risk of bleeding. So it's all a fine balance, but this is what goes on in the background to ensure the safest possible care. The laboratory are so important. If we need to do any blood tests, they're on the case immediately. If any bleeding happens, they phone us before we even ask for results. They are truly tremendous colleagues. Sometimes we involve physicians. We're not normally working in a maternity hospital. For example, if a patient has a background of another medical condition like a heart problem or a respiratory problem or anything else, we are so fortunate to have colleagues who are willing to collaborate and share your care. And also X-ray doctors or radiologists, because the way we diagnose any type of clot in pregnancy is with a type of scan. And so, for example, a pulmonary embolism is diagnosed with a type of CT scan or a ventilation perfusion scan. And here's how the team works. This is so important. We share care antenatally in a high-risk clinic and in the haematology clinic. There is extensive counselling on what to expect, what doses we're going to use, and of course, referral to our multidisciplinary team. We think really hard, and the patient is part of this, about the best way to personalise that plan around delivery of the baby so that the risk of having another blood clot is minimised while simultaneously minimising the risk of bleeding. And that can be done when people are invested and are willing to work together. And we're so lucky that that's the case in the Rotunda Hospital. And then we think about postpartum dosing. And I suppose when we think about diagnosis of pulmonary embolism, one question that I'm asked very frequently is, well, will the scan harm the baby? And the good news is that using modern protocols, no matter what type of scan that your doctor recommends, in this day and age, the risk of radiation exposure is extremely low. To baby, it's negligible, well below the threshold that risk would be seen. And it's important to think about potential risk to mum as well, exposure of radiation to breast tissue. But with modern protocols, the risk of this is incredibly low. Conversely, not diagnosing a PE in pregnancy, obviously, as I said before, is not something that we take a risk on. And again, to address this knowledge gap, you know, what is a good way of diagnosing pulmonary embolism in pregnancy? I'm delighted to let you know that one of our superb radiology teams is working with the Irish Network for VTE Research to do a very ambitious study showing that such a very safe low-dose diagnosis scan is actually safe in pregnancy when we use it to rule out pulmonary embolism. And in this study, the primary outcome, or the thing that they will be measuring, will be the incidence of PE at 3 months in women with a negative scan to begin with. So this is a very simple study design, but such an important study. And again, watch this space. So working together is incredibly important when we treat a pregnant mother or a postpartum woman who has a deep vein thrombosis or a pulmonary embolism. It's so important that we share our knowledge and our expertise. There are lots of knowledge gaps. For years, pregnant women have been excluded from clinical trials, and that's been a real problem for us, because sometimes it's easier to say no to a trial in pregnancy, but then we have to manage very difficult competing risks without good data, and that's just not good enough. Women deserve better. But the great news is that in addition to the studies I described earlier on, there have been excellent international world-class multi-centre studies completed and published recently, and they are achievable in pregnancy. So my take-home messages before we open the floor to questions are awareness, awareness, awareness. We must share that message with every family member, friend, with society. Just know those symptoms and signs of a blood clot. If you know somebody who's had a baby, just make sure that she knows what those signs are, because if we can, then we will not miss an opportunity to potentially save a life. Risk assessment. Mandatory VTE risk assessment is something that is in the Rotunda and should be throughout Ireland, and it is so important because it has been shown to make a difference, and in the UK can save lives when used in hospitalised patients. Shared decision making, working together. It's not just about doctors working together to make a decision. You are part of that decision. And it's, of course, as I said in the beginning, so important to share any risk factors that you think are important so that your doctor can make a better assessment when he or she does your risk assessment. So working together, we can prevent and treat blood clots in pregnancy. Thank you very much. Oh, I forgot to say, huge thank you to the entire Rotunda Hospital and Mater Hospital multidisciplinary team. This is the team in the Rotunda. Everybody is here. And this is Professor Leah Lawler, who's a radiologist in the Mater, who, with Dr. Donnelly, set up and chaired the very first maternal medicine multidisciplinary team meeting way back, I think it was in 2014 or 2013, and it's shared between the Mater and the Rotunda. So all of these people are such heroes, and he still chairs it. And here is Professor Brian Cleary, Dr. Jennifer Donnelly. Dr. Donnelly chairs the MDT and has been responsible for all that work that you heard in relation to the Thrombosis tool, and some of our international colleagues who have done so much to progress excellent quality studies to help progress, to help us make better decisions for pregnant women. And finally, Renata Doncio, who did those beautiful illustrations you saw during the talk. Is that okay, Anne-Marie? Thank you very much. I'll open the floor.
Fantastic. And listen, our thanks as well from Thrombosis Ireland and everybody who's attend to all our VTE warriors, because that's what I call you, our VTE warriors, our guardian angels, researching, looking over us, trying to make things better, trying to make things safer for us. And it's just heartening to know that that's happening out there, and that finally women are being prioritised, particularly our pregnant girls, giving life to their babies, and it's so important that we keep them safe. So I have a couple of questions from the floor. Does excessive morning sickness increase your risk?
Yes, that's a great question. So we know that a condition called hyperemesis, which is at the really extreme end of the spectrum, is recognised to be a risk factor that does significantly increase the risk of venous thromboembolism in pregnancy. So it's definitely something that we take into account when we do a risk assessment in early pregnancy.
Okay, and now more than ever we see multiple pregnancies. Would this be another risk factor?
Yes, I'm going to flip back to the list of risk factors because it was because your participant is absolutely right. Here you are. So multiple gestation, you can see, is a pregnancy characteristic, which means that it's something specific to the pregnancy itself. And again, if you're carrying triplets or twins, your risk of having a blood clot is increased compared to somebody who's only got a single-tip pregnancy. So we might keep this slide open because I think it's really, it was hard to take it all in, I'm sure, at the time. You know, it's worth keeping this open so that people can understand what these conditions are.
So I think what we took from it really here was the absolute importance of mandatory VT risk assessment at the beginning and after the birth, so that because they're two different areas and things can change after the birth, as you said. So we would encourage all of our girls who are pregnant, or if you know somebody who's pregnant, to ask for a VT risk assessment to see what is being done to keep you safe, you and your baby safe, and to prevent pulmonary embolism or VTE during the pregnancy. I suppose I have to draw attention to the fact that I know there's a lot of work going on in the Rotunda, and I know there's a lot of work going on in Holles Street, and I'd like to think it's going on in all our maternity hospitals around the country. I mean, how are we ensuring that every one of our pregnant girls and new moms are hearing this information? How are we ensuring that they're informed of their risk? Because they're not going to be able to protect themselves or spot the signs, as we say, if they haven't been informed. So are we actively informing every single pregnant girl?
Yeah, so thanks very much. Can you still hear me, Anne-Marie?
Yes, perfectly.
So first of all, just to say that we talked about the high-low study and the important the world-class studies that are ongoing, and that is definitely not just the Rotunda. We've got participating sites all around the country, so huge shout out to everybody. I think there isn't a maternity unit in the country that hasn't become that isn't engaged in this process, and there are, secondly, national guidelines that all maternity units follow, which is really great. There are international guidelines, but I think I agree with you, Anne-Marie. Nationally, there are certainly strategies that we can employ to make sure that not just women who are in the maternity hospitals hear the message, but also those who are planning to become pregnant, who know women who are pregnant, who have had a baby recently, and I think that message, know your signs, know your symptoms, eyes open to thrombosis, is a message that we need to sing from the rooftops.
It's a household message, isn't it? We need to get it into every home so we can all protect each other. Because look, I'm just really conscious. I actually know my friend on the road, her daughter just had a baby, and I asked her genuinely, and she's from she was attending a very active hospital. Was she aware of her risk of VTE? And she wasn't. And so my concern is that it's not getting to the girls on the ground. Yes, I think our midwives and our hematologists and all the professionals in the hospital are really working hard and researching, but I think we really need to work a little harder to get it to every girl that comes through that door. Thrombosis Ireland as a whole will try and hit the whole community, like the public message. But I think that a really concerted effort has got to be made, that if a girl comes in and is pregnant and goes for her first checkup, that she needs to be informed of that risk immediately, and then she needs to be reminded of that risk, and her husband needs to be, or her partner needs to be reminded of that risk before she goes home. And we can't shout it loud enough or say it enough times.
And So I think what's really interesting, Anne-Marie, is I don't think we know where the gaps are truly on a national level. So I think it would be incredibly interesting to as part of any campaign, understand really how many women out there don't know and how we can do better. You know, what are the media that we can use to deliver that message. And in this day and age, we can be so much more inventive, and there are platforms out there that I am not even aware of, I'm sure, but certainly through social media, and there are huge opportunities there. And congratulations to you and Thrombosis Ireland for all the work you've been doing on social to promote that message. World Thrombosis Day as well is working really hard on an international level to amplify that message. And really, I think that you must all know what the signs and symptoms of a PE are, particularly after baby's born. We can't shout that loud enough.
Yeah. So there's one more question come in here. Hi there, is it the same process of risk assessment for women who have had CVST? And is there any research or studies done on pregnant women who have previously had CVST? I'm on Warfarin for life, have been told I can swap to heparin for pregnancy, but worried about the risk to both baby and I. Thanks.
Yeah, thank you, Anne-Marie. And yes, your caller, hello, I hope you're doing well, and look, it's such a traumatic thing to have gone through. CVST is a very rare form of blood clot, but it falls under that risk category of prior VTE. So it is a rare type of VTE. For simplicity's sake, sometimes we talk about deep vein thrombosis and pulmonary embolism, but CVT is one of those, and certainly there is a high risk of thrombosis during a pregnancy, and that is why that shared care pathway, making sure that planning is done well in advance, that strategies. I'm not sure if the lady who put through the question is on anticoagulation for life. Is that right?
Yes.
So in that scenario, her doctors will make a plan to switch to a safe form of blood thinner throughout the pregnancy, and that will be low molecular weight heparin. So obviously warfarin can't be used during pregnancy, but yes, CVST falls under the category prior VTE.
Yeah, so really she's not to worry that this is a well-trialed, well-used drug that's been used for many years, and that you're well used to using it, and also that her and the baby will be kept safe because she'll be under a multidisciplinary team.
Exactly.
Okay, that's brilliant. Okay, so thank you so much, Professor Leonia. That was absolutely brilliant.
I'm really well done.
Some more questions here, and it was really interesting presentation, and it will be available on our website as well over the next couple of days. But if anybody wants to look at it again today, they can just click back into the link and it's available to watch immediately. Stay on the line there.
Okay. Thank you, Anne-Marie.